Hmm. Gastrointestinal hormones. GI hormones act upon the GI tract and the brain. Classification of GI hormones in three main families: gastrin family, secretin family, and others. Gastrin family has gastrin and cholecystokinin. Secretin family has secretin, glucagon, vasoactive intestinal peptide, VIP, gastric inhibitory peptide, GIP, other hormones like motilin, ghrelin, peptide YY, ghrelin. Next hormone is peptide YY. Stimulus is fat-rich diet. It decreases gastric motility and it decreases acid secretion. This is in the diagram, you can see it's in the stomach. Peptide YY will bring decreased gastric motility and decreased acid secretion. In the large colon and then in the small intestine, you can see it is inhibiting ileal motility, ileal brake in the small intestine, in the ileum. Ghrelin, also known as hunger hormone, causes hunger contractions. It is secreted from the oxyntic gland in stomach. Levels peak during fasting. Levels are high in anorexia nervosa patient and low in obese patients. Actions: orexinergic, increased food intake, increases gastric acid and increases gastric motility, increased adipogenesis, increased release of growth hormone. Ghrelin is growth hormone, and then REL is releasing. Ghrelin increases growth hormone. Moving next to digestion and absorption. First is carbohydrates. In the diet presents as polysaccharides. Starting from the mouth, it has salivary amylase in saliva, which is activated by chloride ions and is inhibited by gastric acid. In the stomach, no enzymes play a role in the digestion of carbohydrates. In the pancreas, we have amylase, which is the major enzyme. It acts on 1:4 alpha linkages and makes them into disaccharides. Disaccharides reach the brush border enzymes in small intestine, such as lactase, isomaltase, sucrase, which act on 1:6 alpha linkages and convert them into monosaccharides, such as glucose and fructose. Absorption. This is a blood capillary and a adjacent intestinal cell. In the lumen side, you can see transporters like GLUT5, that is for the transport of fructose. And on the capillary side, you have GLUT2 and GLUT5. SGLT1 is found in GIT, secondary active transport. Fructose entering into GLUT5, glucose entering along with sodium in the GLUT5 channels, going to GLUT2, facilitated diffusion of glucose into the blood, fructose going through GLUT5 into the blood. Clinical aspects. Sodium absorption is facilitated by glucose absorption via SGLT1 channels. Congenital glucose galactose malabsorption, CGGM. Congenital glucose galactose malabsorption is the congenital absence of SGLT1, that is sodium glucose cotransporter 1, absent in congenital glucose galactose malabsorption. Genetics: autosomal recessive presentation, chronic refractory diarrhea. SGLT2 is found in kidneys. Lipids. In the diet, it comes as triglycerides, Mouth has lingual lipase, stomach has gastric lipase, pancreas has pancreatic lipase, co-lipase, cholesterol esterase, acts on triglycerides and forms free fatty acids. Absorption, micelle formation, bile salt, salt micelle, free fatty acids, cholesterol, fat soluble vitamins A, D, E, K, high concentration, passive diffusion, mucosal cell, low concentration, free fatty acids, re-esterification, triglycerides, transported by chylomicrons. Emulsification mechanism. Bile salt plus fat globule prevent formation of large fat globule. Use increase action of lipase, facilitates digestion and absorption of lipids. Enterohepatic circulation, liver and terminal ileum occurs 6 to 8 times a day. Reduce forming new bile salts, conserve energy. Note short chain fatty acids. For example, propionate butyrate acetate formed by colonic flora, function trophic action, increased mucosal growth, acid base balance absorbed in exchange for ions like hydrogen ion, and prevents inflammation, short chain fatty acids. Protein presented as polypeptides. Mouth, there is no enzyme for protein digestion. Stomach, you have pepsin. Pancreas, you have trypsin. Small intestine, you have chymotrypsin and carboxypeptidase. Endopeptidase is the enzyme, such as, for example, trypsin and chymotrypsin, because it acts on the inner region of peptide bonds. Peptide polypeptides have a carboxy end and a NH2 end. Exopeptidase, it acts on the end region of peptide bonds. Aminopeptidase and carboxypeptidase. Type of pancreatic enzymes, endopeptidase and exopeptidase. Exopeptidase are aminopeptidase and carboxypeptidase. Small intestine presents trypsin, chymotrypsin, carboxypeptidase. They present in the form of thymogen. Inactive prevents autodigestion of pancreas, acute pancreatitis, activated in small intestine and forms dipeptides and tripeptides. Absorption, blood amino acids, basolateral amino acid transporter, dipeptides, tripeptides, converted into amino acids, cytoplasmic protease, dipeptides, tripeptides, peptide transporter. Sodium proton exchanger is in the lumen end. Sodium proton exchanger. Vitamins and water absorption. Vitamin absorption, fat soluble vitamins absorbed along with micelles. Water soluble, B complex absorbed by sodium dependent transporters, except B12 and folate transported independent of sodium. Water is absorption. Total water content in the GI tract is 9 liter. Water reabsorbed is 8.8 liter. Water excreted in stool is 200 ml. Maximum water is absorbed in jejunum. Iron absorption mechanism. Iron absorption depends on dietary iron intake, body iron stores, and state of erythropoietic activity in bone marrow, which is increased by vitamin C, and factors like tannins, oxalates, and phytates decrease it. This is a cell in the duodenum. On the lumen side, you have heme transporter and food is giving you heme iron. Then you have ferrous and ferric iron. Heme iron is going to heme transporter. Ferric iron is non-heme iron is converted to ferrous iron, is going to DMT1 transporter. Duodenal cytochrome B is helping ferric iron to change into ferrous iron, and then ferrous iron is going into the duodenal cell via DMT1 channel. In the cell, the ferrous iron meets with the ferrous iron released from the heme, and then mucosal ferritin can be lost by epithelial shedding, and the rest is using ferroportin 1, which is inhibited by hepcidin, and it goes again as ferric iron, now converted by lipestin, and ferric iron is going into blood with plasma transferrin, erythroid marrow. Hepcidin is coming from liver. Regulation hepcidin, negative regulator. Hepcidin is released from the liver. Genetics, HFE gene. Mutation, hemochromatosis. Function, represses basolateral transport of iron into blood. Binds to ferroportin. Iron not released from macrophage and other cells. Links body iron stores with iron absorption. Gastrointestinal motility. Interstitial cells of Kajal, which is the pacemaker of GIT and has a restless membrane potential location. Mid-body region along greater curvature is your interstitial cells of Kajal. So your closer look. GIT smooth muscle, interstitial cells of Kajal, single unit smooth muscle, autonomic neuron, transmitter and gap junctions. Apply aspect. Gastrointestinal stromal tumor just arises from interstitial cells of Kajal. BER, basal electrical rhythm. BER, basal potential oscillating between -60 to -40, has no role in muscle contraction, action potential, and spikes. Basal electrical rhythm on crossing threshold -40. Phases depolarization is due to calcium influx. Repolarization is due to potassium efflux. Causes smooth muscle contraction. Here is the diagram of restless membrane potential. Basal electric rhythm is oscillating between -40 to -60. Depolarization is due to calcium influx, and repolarization is due to potassium efflux. Threshold is -40. Action potential is shown. Effect of autonomic nervous system. Parasympathetic nervous system uses acetylcholine. It increases the number of spikes, increased force of contraction, and increased tension generated. Sympathetic nervous system norepinephrine uses norepinephrine. It causes decreased in the number of spikes, decreased force of contraction, and decreased tension generated. Frequency of basal electrical rhythm, that is oscillations per minute. In duodenum, it is 12, highest. In ileum, it is 8. In stomach, it is 4. And in cecum, it is 2. Motility in GIT during fed state. Food in mouth, deglutition, process of swallowing. Oral stage is voluntary. You can see the tongue, pharynx, and windpipe trachea in this image. Behind the trachea, you have your esophagus. Pharyngeal stage is involuntary. You have your vertebrae, soft palate, and larynx closes. Esophageal stage is involuntary. You have your epiglottis. Deglutition reflex coordinates swallowing. Food in mouth is a stimulus. Cranial nerve, fifth, ninth, and tenth. Efferent nucleus tractus solitarius in medulla center. So cranial nerve, fifth, ninth, and tenth. Afferent nerves goes to nucleus tractus solitarius in medulla center. Efferent nerves are again trigeminal, facial, and cranial nerve 12. Innervates pharyngeal muscle and tongue effector, and hence the action of swallowing is performed. Food in esophagus. Peristalsis is the mechanism. So esophageal stretch releases serotonin, then it activates mesenteric plexus, it starts the peristalsis. Physiological law of peristalsis is from oral end to anal end. Contraction push food forward due to acetylcholine and substance P. Relaxation retrieve food due to nitric oxide and vasoactive intestinal peptide. Pathological is reverse peristalsis, that is from anal to oral end, which is seen in vomiting. Types. Types is primary, secondary, and tertiary. Primary and secondary are progressive movement, tertiary are non-progressive movement. Primary is seen physiologically, secondary is seen in esophageal irritation, and non-progressive is esophageal spasms. Clinical aspect: absence of nitric oxide, acetylcholine overactivity, a sustained contraction of lower esophageal sphincter, achalasia cardia. Treatment is botulinum toxin, Botox, which inhibits acetylcholine release. Normal physiology: acetylcholine concentrations are equal to nitric oxide concentration. Lower esophageal sphincter is shown in the image. Food in stomach: gastric emptying. Pyloric sphincter opens momentarily in the distal end, and this is the proximal end. Receptive relaxation used for temporary storage of food. Retropulsion used in mixing and grinding. And gastric emptying is the third phase. Factors affecting gastric emptying. Factors increasing gastric emptying is increased gastric volume, increased gastrin, increased motilin is increased acetylcholine, increased substance P and potassium and serotonin. Factors decreasing gastric emptying is increased carbohydrate, fat, protein, rich, acid, hyperosmolar content in duodenum. Causes positive reflex on enterogastro reflex, inhibits gastric emptying. Local enteric reflex at GIT. Nitric oxide, VIP, cholecystokinin, dopamine, and enkephalin. Clinical aspect. Gastrocolic reflex. Defecation in newborn following a meal. Reflex stomach distension due to food. Increased colonic motility. Defecation amplified by gastrin. Food and intestine. Small intestinal motility. Segments. Both ends compact, slow movement of food, adequate time for digestion and absorption. Segmentation: factors affecting motility. Factors increasing motility are parasympathetic nervous system, motilin, gastrin, cholecystokinin, serotonin, gastroileal reflex. Factors decreasing motility are sympathetic nervous system and secretin. Large intestinal motility. Large intestinal motility is by hausturations, combined contraction of circular and longitudinal muscle, absorption of water and electrolytes. Mass movements moves along segment, rectal distension, increased motility, defecation. Number one is proximal colon, two, three, four are distal colon. Rectal motility, defecation reflex. Muscle, smooth muscle nature, involuntary. Effect, ANS, PNS relaxes, facilitates defecation. Sympathetic nervous system contracts, inhibit defecation. Muscle is skeletal muscle in the external sphincter. Nature is voluntary. Nerve is pudendal nerve. Mechanism is rectal distension via stretch afferent, goes to spinal cord. Parasympathetic nervous output relaxes internal anal sphincter. If situation favorable, powerful contraction of abdominal muscles, rectum and colon, and relaxation of external anal sphincter. Rectal pressure 18 mm Hg is the first urge to defecate. 55 mm Hg is voluntary control loss, sudden inadvertent release of internal and external anal sphincter soiling. Transit time: esophagus 2 to 3 seconds, stomach 2 to 5 hours, small intestine 3 to 6 hours, cecum 4 hours. Proximal one third of colon, 6 hours. Distal two third of colon, 9 hours. And sigmoid colon, 12 hours. So if you see esophagus, few seconds, then from stomach to proximal one third of colon, you have average of 5 hours in each segment, and then distal two third and the sigmoid colon, you have average of more than 10 hours. Note, dietary fibers and roughage, for example, lignin, pectin, cellulose, hemicellulose. Source is cereal grains, fruit, and vegetables. Functions adds bulk to the diet, so decrease food intake, slow absorption of glucose, and reduces total and LDL cholesterol. Add bulk to food, retains water, roughage, microflora, short chain fatty acids. Roughage is converted by microflora. Prevents colonic diverticulum. Motility in GIT during fasting state. It's by migratory motor complex. Seen in fasting and interdigestive period. Mechanism stomach. Migratory motor complex transports to colon. Occurs once in 90 minutes. Rate 5 centimeter per minute. Regulation. Motilin timekeeper released from more cells. Increased GI motility. Erythromycin acts via motilin receptors used for treatment of gastroparesis in diabetes. Functions helps in clearing foreign body bacteria and undigested food. So here you can see maximum amplitude in the diagram. No activity, crescent stage, irregular activity, regular activity. That's the end of digestion. Please like and subscribe and watch next video to complete your course with me. All you have to do is just listen 2-3 times. Cells, I cells, S cells, K cells, no cells. Hormone secreted. G cells secrete gastrin, I cells secrete cholecystokinin, S cells secrete secretin, K cells secrete GIP, gastrointestinal peptide, Mo cells secretes motilin. Note, M cells are microfold cells of pair patches in terminal ileum. Gastrin family. Gastrin secretion is from antral distension. On eating food, stimulation of G cells and gastrin secretion increase hydrochloric acid. Pepsinogen converted to pepsin. Positive feedback for more stimulation of G cells and more gastrin secretion. Pepsin also causes protein digestion. Factors affecting release of gastrin. Release of gastrin is increased by antral distension, protein-rich diet because of increased pepsin, gastrin-releasing peptide, GRP by vagal nerve endings, calcium, ions, epinephrine. Secretion is decreased in excess acid, somatostatin, which is a universal inhibitor, gastrointestinal peptide, and secretin. Actions. Actions increases acid production via cholecystokinin B receptors, lower esophageal sphincter contraction, prevents reflux, protective action, the increased gastric motility, increased pepsin levels. Trophic action stimulates GI tract, mucosal growth. Actions of gastrin are thus as follows. Cholecystokinin, pancreozymin, CCK PZ. Secretion and action of CCK PZ. Intake of foods rich in fats, proteins, stimulation of I cells, which release cholecystokinin pancreozymin actions. Specific actions cholecystokinin via CCK-A receptors, cholagogue contraction of gallbladder, release of bile, relaxation of sphincter of Oddi. PZ pancreozymin stimulates secretion of enzyme-rich pancreatic juice. GI actions augments actions of secretin, stimulates intestinal and colonic motility, inhibit gastric emptying. CNS action, decrease food intake by increased satiety, implicated in anxiety, aids in analgesia. Secretin family, secretin, also known as natural antacid, first hormone to be discovered by Baylis and Starling. Secretion, acid-rich chyme breaches duodenum, stimulates S cells, which secretes secretin. Release of bicarb-rich alkaline pancreatic juice for acid neutralization. Augments actions of cholecystokinin, decreases gastric acid secretion. Contraction of pyloric sphincter prevents food from moving into the intestine. Gastric inhibitory polypeptide, known as glucose-dependent insulinotropic polypeptide. So, gastric inhibitory polypeptide, that is GIP, now known as glucose-dependent insulinotropic polypeptide secretion. Oral intake of glucose stimulates K cells, which releases glucose-dependent insulinotropic polypeptide, which stimulates beta cell in pancreatic islets, which increases release of insulin. GI hormones that increase insulin secretion are called incretins. For example, glucose-dependent insulinotropic polypeptide and glucagon-like peptide GLP. Vasoactive intestinal polypeptide is released and actions are on salivary glands, stomach, and on intestine. On the salivary glands, it potentiates action of acetylcholine. On the stomach, it decreases acid production. In the intestine, it increases fluid and electrolyte secretions, also causes relaxation of smooth muscles. VIPoma, neuroendocrine tumor, which secretion of VIP, that is vasoactive intestinal polypeptide, leads to WDHA syndrome, also known as pancreatic cholera, Werner Morrison syndrome. WD is watery diarrhea, H is hypokalemia, and A is achlorhydria. Watery diarrhea is due to increased fluid and electrolyte secretion. Hypokalemia is due to increased potassium secretion. Achlorhydria is due to decreased acid production in the stomach. Other hormones like motilin, it is seen in all fasting individuals, causes to increase GI motility, regulates migratory motor complex MMC from stomach to colon. Erythromycin, agonist to motilin receptors, used to treat gastroparesis in diabetic patients. Erythromycin is an agonist to motilin receptors, which is used to treat gastroparesis in diabetic patients. Guanylin increase chloride secretion in the GI tract, structurally similar to E. coli, molecular